Thank you, and it's nice to be back here. I've been here in 2018, and I suppose just reflecting on how much we've progressed really since then. Not as much as we should have done, that's for sure. So tonight I want to talk about social care in the four nations of the UK, particularly thinking about what's been achieved we were particularly focusing in the research on the sort of 20 years since those devolution settlements that happened just when New Labour came in, so around 1998. So our field work took us up to 2021. Look at what's been done, what hasn't been done, and in particular something that I'm really interested in exploring, and maybe people in the room might have views on, is whether this is a policy problem or a politics problem. So what is it that kind of stops us making progress in this space? Other countries have done much more than we have to modernise and to meet the demands and expectations. Finish with this idea of sort of decay and thinking around sort of decay across the whole system, and then just briefly touch on a national care service and whether and why and how that might take us further forward. So it's a sort of, this talk is a assemblage of a range of research projects that have looked at things related to this. My colleague Patrick Paul and I had a book out in 2023 around social care in the UK's four nations, and I'll draw quite a lot on that research tonight, but also bring it up to date with some of the work we're doing in more recent projects. But as ever, this is a team effort, so in particular, Patrick and Emily have been very involved in the work I'm going to talk about tonight. But yes, not the funders whose views are not represented here particularly. So I wanted to start with a definition. This is probably a little bit too small for people at the back, but I thought we can't all assume that we necessarily all know what we mean by this term social care. It's a very UK term. People elsewhere talk about long-term care. So just to begin really by saying kind of what's in scope here in terms of support for disabled people, people with age-related frailty, long-term mental health conditions and unpaid carers. There are a number of ways you could define adult social care. There are functional definitions, and those might be the ones that are using a local authority assessment to see can you do certain things around activities of daily living. So there's some jargon around that. But I think it's increasingly talked about in a way that I find much more alluring in terms of what's it for? You know, it's not just about being able to get out of bed and get some breakfast, it's about what kind of life you want to lead. So I think the kind of definitions and the ways into social care emphasise getting a life, not a service. That's one kind of expression that's sometimes used. Or this expression which came out of a report that the House of Lords Adult Social Care Committee did in 2023, that it's about a gloriously ordinary life. So the sense of kind of what is being advocated for is access to the opportunities that many people have already, and just to have those would be glorious, and that's an aspiration for adult social care. Just a couple of points around how it's organised and who does it, which is important when thinking about who needs to do something different in this space. So this is not an NHS service, so it's, again, that's different from some other countries where it's more closely linked to the health system. So here, this is a local government responsibility. So it's managed by local governments. So that means in England we have 150 odd different social care systems because of the different local authority decisions around how social care will be allocated. And it's also means tested, unlike the NHS. So that means if you have assets over a means test threshold, you will not get support from the state, that you'll buy care yourself. And that's a hugely important factor in thinking about how and why we might perform care. We often come at these things through the lens of the state, but it's hugely important to recognise that the vast majority of care is delivered not by the state, it's delivered by family members, it's delivered by friends, it's part of the unpaid care system. So the census had around 10 million people in England delivering unpaid care. So that is a huge bedrock of social care. And again, that's really important around thinking about how we reform it. So formal care, which might be provided by the state or by the market, is a much smaller sector that sits often on the top of the kind of contribution of unpaid care. And community has a role to play here, but that's quite a term that's often kind of hard to define. But in terms of thinking about going back to that notion of kind of what makes a good life for people, it's often the ability to get out in the community and do things that you enjoy with people that you like. be they hobbies or faith groups or places to go and have lunch. So thinking about the community as a place to go and ways of connecting, not always in place. Obviously, there's other kinds of communities, but we know that community is a big part of what makes a meaningful life for people. So because social care is complex, it's got the kind of the on that sort of supply side, family, state, market, community. It's got all the different elements in terms of the local authority. One of the things we wanted to do in the current project that we're doing in the Centre for Care was think about a care system, so think about a whole care ecosystem, and how we might go about kind of mapping social care or kind of visually rendering the social care system. So we started by looking at what was done with other systems. You've probably seen this before because it's slightly notorious as a kind of system map, but this is nothing to do with social care. This is the government's obesity map, looking at some of the causal pathways and some of the different factors involved in obesity. Clearly from there you can't see any of the words, but the point is it's a big old mess, and it's quite difficult to use this to kind of as a way to operationalise or think about policy intervention or how you might do things differently or who might do things differently. So it's a great way to kind of capture the complexity of something, but not maybe to go very much further. So we thought about a different kind of way of representing the social care system, which is to take that ecosystem metaphor and to really lean into it, into the sense of kind of if we thought of care as having some of the elements of a natural landscape, what might that look like? So working with people with lived experience, we developed the image you can see here. And I guess a couple of things to take out of it. First of all, in terms of its scale, we're thinking here about maybe a neighbourhood or something a bit bigger than a neighbourhood. It's got a hospital, it's got some social care facilities on the left. And those are the visible bits. So the social care on the left, the NHS, the associated services on the right are the visible bits. They're really important. But actually we have this sense that a bit like in a garden where the real kind of what makes everything else possible is hidden in the sort of tiny microorganisms in the soil, that actually what makes social care possible are the bits which are quite invisible to us as researchers and to the state. They're the things that allow people to stay connected, to give them meaning and purpose in communities. And we need to be thinking about that as just as important as the bits that we can measure and visit and see much more visibly there, because we cannot, a social care system that was entirely made up of those formal state-funded services would collapse because there is not enough money to pay for that. It relies so much on the things that go on underneath that and what that makes possible for people. So this is a kind of normative image in that this is a flourishing care ecosystem. This is sort of what we would like it to be. A lot of the time it might feel a bit more like this. A sort of bleached and degraded landscape with too many parasites and not much going on in the way of life and vitality. So in our research and the kind of conversations we're having, we're partly thinking about how might we be making sure that we're moving towards something that looks more like that kind of flourishing ecosystem. And one of the reasons why I think the care ecosystem often feels degraded or depleted, to link to a future seminar, is because of the way in which it's been perceived to be, and to a large extent has been, in crisis over the 2 decades that we've been doing this research. So partly this is a demand issue, so we know that about the kind of demographic changes that have increased demand on social care services. In lots of ways, those are great things and things that we might really want to celebrate, but they do mean that a system which was designed in the post-war period for a very different kind of demographic profile is not now really fit for purpose, and the fact that it's been left relatively unreformed since then is a problem. I said earlier we've got kind of 4 elements on the supply side, and we could to some extent see each of those as having their own separate element of crisis. So we know that some of this comes from the family, changing family structures, changing geographical patterns of families, that in some senses families get criticised for not doing enough because they're at a distance, but nonetheless the fact that actually one of the kind of real problems is the overloading of family carers and the intensity of care that many family carers are providing, so that's sort of doing too much rather than too little. This is a crisis to some extent of the state and state underfunding, in the sense that the argument that's made that it's not affordable for the states to do much in this space. Obviously, that's a kind of an argument that's made and we can interrogate. But I think it's also important to recognise that the state, when it did do more, did not necessarily do it well. That there were historical funding. That the state is not a good corporate parent. It's not a good. Didn't necessarily provide good quality care for people in long-stay institutions. So there isn't a sort of golden age of the state to go back to in relation to long-term care. We know there's problems around the market. Some of that's around profit extraction by private equity-backed large providers. Some of it is about the instability of providers that are struggling to get by on the amount of state funding coming via local authorities that we know are just actually not really enough to cover costs, leading to lots of cross-subsidy from self-funders, leading to a sense that this is a fairly unstable market. Things like the rising national insurance rates then can start to put pressure on some providers that are quite near the edge. And then a sense of community in crisis. A lot of the third sector voluntary organisations that did get bits and bobs of state funding have really struggled through the period of austerity. We know that that's likely to continue, and maybe there isn't a sense that we fully recognise all those sort of invisible connections, and we don't properly value them. And if we don't do that, then we're potentially removing a really important element of what makes a good life for somebody. So these are crises, but we might see if we focus on the four nations of the UK, so Scotland, Wales, Northern Ireland, and England, that these have been experienced somewhat differently in the four nations over that kind of 20-25 year period since devolution. So in England, it's very much a crisis of austerity. We know that in that period, public spending on care fell quite substantially, and that local authorities in particular have been enormously affected by decline in their fiscal base, their ability to fund social care. So there's a clear problem around public service austerity. And I think when you layer on top of that, the pressures created by Brexit, and the COVID crisis, then you have a sense of kind of a state that wasn't able to act very effectively in this context. In Scotland and Wales, so Scotland care funding went up a bit, in Wales it stayed around the same, so that we don't have quite the same sense of kind of fiscal pressures. But there, I mean, Wales has got the oldest population and the largest number of disabled people, so they're framed much more in terms of the kind of the demand and meeting the demand and what kind of system might need to be in place in order to meet that. Northern Ireland funding went up quite significantly over the period, and the crisis there is much better understood not as one of kind of austerity so much as institutional stasis, that in the absence of an executive for large parts of this period, it was very difficult. I've lost my screen, I'm just going to carry on. It was very difficult for to get where we needed to be in terms of the making actual progress in terms of legislative change, and thinking differently about kind of system redesign. So different issues there that we might see in Northern Ireland. And in terms of the kind of responses to the crisis, it was evident from the research that we did. So this was an interview-based project where we also looked at policy documents, some of the legislation, key white papers across the period, that we could see in Scotland and Wales a much more of an articulation of a sort of social democratic way out of the crisis, which is a greater role for the state. In Wales, particularly backed up by a sense of kind of mutuality and co-production. Whereas in England in particular, it was much more, we need to do more to kind of incentivise the markets to be active in this space, that the route out of the crisis will come from the market. So having articulated what the kind of, we could see the crisis as being in the four nations, then that gets to the question of kind of what we've seen in response. Is it a question of delivery, drift, or decay? So over that 20, nearly 25 now years since devolution, we could say that if we think of delivery as substantive legislative change, then we do see particular kind of pockets of that, and particularly in Scotland. So free personal care introduced for people over 65 in 2002, since been extended more recently to working age disabled people. So obviously that's a huge kind of intervention in a sector. It's, I mean, one thing it offers is a potential for sort of policy learning in England. We sort of talk about, well, is that one of the things that a national care so should consider? Well, then we've got 20 years plus data in Scotland to be looking at to see what impact it's made there. In Wales, they haven't gone as far as that, but there has been some capping of spending. So there is a maximum weekly charge for home care in Wales, and they have changed the means test threshold. So it's a much more generous means test threshold in Wales. Your assets are, so compared to England, around 23,000. It's around 50,000 in Wales, so much more generous there in terms of who's able to get state-funded care. In Scotland, they were very excited around 2012 with the self-directed support legislation, in a sense that that was going to be a real kind of key pillar of their of how they took forward their approach to social care, to really lean in around the kind of co-production self-directed support agenda. We can see in all of the, well, 3 of the nations, better rights for unpaid carers. So Northern Ireland is the kind of laggard there that hasn't updated its legislation to bring it into line with the other parts of the UK. And in Scotland, again, something in terms of actual kind of investment, we can see the raising of carers allowance in Scotland as being another kind of progressive step, hopefully in the right direction, in order to bring some more support to carers. In Scotland, Wales and Northern Ireland, we've got care worker registration. So we know that one of the things that people think might help social care is to make it more of a registered profession, to move it more in the direction of nursing. And we do see that in 3 of the nations, they've moved in that direction, but not England as yet. And in all of them, we can see steps to become more integrated with the NHS. So Northern Ireland, they've had that for a long time. It's not necessarily worked very well. But they're trying to kind of refresh that. But integrated care to try to sort of end this real sense of a kind of chasm between the health and social care has been a key commitment. So it's not that nothing has happened. There's clearly been stuff done. I think particularly in Scotland, there was a sort of 20-year period up until around COVID, when it was really very active in terms of legislation. But there's also been lots of drift. So Patrick and I wrote about this in an article for Social Policy in Administration. So we might think about, you mentioned Andrew Dilnott in your introduction, who suggested a care cap back in the report in 2011. It was passed into law in 2014. They decided not to implement it straight away, but make it till 2017, and then it kind of quietly went away. Then revived by Boris Johnson, put again into legislation in the Health and Care Act 2022, then delayed and now abandoned. So a sad story of the care cap. Not in the period of our research, but more recently, the National Care Service in Scotland, something where it really looked like, again, Scotland was going to take the initiative and do something quite interesting, not necessarily what everybody would have wanted. Heard just recently that that one now won't be going forward. Some of the legislation that was passed has been poorly implemented, in the sense that carers legislation and some of the self-directed support legislation has not really been much loved by the government once it was passed. Some of the kind of optimism about it has not come off. Northern Ireland remains stuck in terms of its legislation. It still draws to some extent on the National Assistance Act 1948, backed up by some directives, but not new legislation to bring it into line with the rest of the UK. And integrated structures with the NHS have not yet achieved all the things that people are very optimistic that they might achieve. And it's a bit of a jam tomorrow situation, I think, in that it's always just out of reach, this kind of the sort of the holy grail of really bringing these 2 institutions together. So in terms of explaining drift and why we can see this pattern, we draw on some of the literature, some of the new institutional literature. Hacker has written about the notion that the formal policy is the same, despite new social risks, which we've been seeing around demographic change, with which existing programmes are poorly equipped to grapple. And this concept of drift, in the way that it's been conceptualised, it's deliberate, and it requires reform solutions available but not adopted. So what we did in the 4 Nations book is we looked at these 6 elements of drift to see whether they were evident in the 4 nations of the UK. The cost is around the kind of affordability, other concerns about the affordability of reform. Partisan polarisation refers to the extent to which there is a kind of clear political consensus, or whether this is a kind of an issue which is dividing the parties, whether there's scope for kind of political capital to be made. Veto players refers to the kind of interests who sit around the policy, who might be wanting to limit its effectiveness, to steer it off course, to make sure it doesn't happen. Automaticity relates to the extent to which there is something inbuilt in original legislation, which means it keeps up to date. So anything which has got a kind of, which is linked to inflation, we might say to some extent has that kind of automatic uplifts in it. So change can happen without needing new legislation. So we're looking at kind of, is that something which is evident here? Agenda capacity, can the government get on with it? Is it too distracted with other things? And then the kind of a sense of kind of, if we do intervene, can we be confident that this is the right thing and it's going to give us the outcomes that we want? So we looked at each of these in our 4 nations. So this is based on, say, on interviews and document analysis. And what we found was that England had all of these elements which might lead to nothing happening. So it had all of the drift factors. You know, particularly something like the strong role for the Treasury in shaping care, whether anything happens around care. So we can see that from the kind of cost perspective, but also from the veto players. The kind of lack of automaticity in the sense there's no uplift. So the means test sits now where it sat in 2011. So in that sense, that's been, particularly with inflation being so high, that's a significant cut in the generosity of the means test. Scotland, where we had kind of 20 years suggesting that it was doing quite well, had, when we did the analysis of this in 2022, had few of these drift factors. But we would argue in that period since then, with the resignation of Nicola Sturgeon and the kind of some of the sort of political turmoil since then, and the problems of the National Care Service, we'd say that actually some of these issues around partisanship and veto players are now much more evident in Scotland than we were when we did our research. So those kind of weren't there originally, but I think they were growing. Wales, which had had a kind of not such a expansive institutional legacy from devolution, took a while to get its institutions going, struggled with things like agenda capacity, but has now been able to move closer to what Scotland got. And Northern Ireland has generally suffered. Where it hasn't suffered is in money, because it's invested more in social care, and that being automaticity, because it's social care and health are put together, then it gets the same automatic uplifts that the NHS has been getting, not in an easy or necessarily effective way, but that's one example where you can kind of build in automaticity. If you've got an NHS that's getting an uplift, then that can help social care if they're combined. So I guess a question that I really like to get into then is this a kind of, if we've got seen all this drift, not much has happened, we kind of understand some of the reasons for drift, but considering really how much these are policy problems, can we get the policy right, and how much these are politics problems around parties and interests and the money side. So an article that we just had published in Policy and Politics, we look into this, particularly in relation to England, and we use May's work around policy failure, where he draws out the 3 I's, you might be familiar with from other work, of ideas, institutions and interests. So looking at the kind of way in which those 3 shape policy failure. So if we start with ideas, and we kind of say ideas is sort of the policy bit, the bit where it says, have you got the right kind of ideas? Do you know whether they're going to work or not? We would say in relation to drift that relates to the sort of uncertain outcomes bit. So can you be sure if you pass this policy, it's going to do the things that you want to do? And what we found in our Care in the 4 Nations research in terms of policy was that they were all kind of trying to do the same things around policy. They were doing it in slightly different ways, but actually it was all about, if you looked at the policy documents, it was all about, you know, well-being, fairness, and these principles that we see here. And kind of interestingly, the policy mechanisms that sat underneath those goals were also quite similar. So they were all trying to redistribute the cost, recognising there's too much self-pay in social care. They were all trying to make social care more personalised, more person-centred, language of self-directed support used in some of the nations, because a big part of personalisation is too English and too market, but nonetheless the same kind of idea of kind of giving the power to the person. More for unpaid carers, let's invest in prevention. Everyone loves prevention, don't they? It's sort of seems to promise so much if we can just get prevention right. Ditto, integrate with health. There's too many people are kind of falling between the gaps. and then do something to professionalise the workforce so that it kind of brings in the kind of the status and eventually perhaps the pay that might make it more equivalent, more attractive for them to help. So looking at those policy mechanisms, one of the things that we found was that across all the nations, not enough attention was given to what we call the policy mix. So the sense that if you're trying to do, so we had 6 things on that previous slide, if you're trying to do them all at once, which these nations on the whole were trying to do, then people weren't thinking enough about the sort of additive elements of this and the extent to which once you start trying to do them, they start to interact, and we need to think about kind of what happens with them as a totality. So some of the kind of thinking about the policy mix was a tactical one. So we could say in Scotland, they did do things more sequentially. So whereas in England and Wales, they had big set-piece social care legislation, like the Care Act of 2014, which did a bit of everything. In Scotland, they went at things much more kind of one after another. So they did the free personal care, then they did self-directed support, then they did integration with the NHS, and in a sense there was a bit more time for things to bed in before they moved on to the next policy. But even then, what we found was that there wasn't really enough attention to some of these tensions in the policy mix. And really the conclusion of our book on social care in the 4 nations was that not enough attention is given to these 2 paradigms, which is, do we want social care to be more differentiated, more person-centred, more locally produced, more engagement with communities, or do we want it to be more standardised, regulated, consistent, safe, and integrated with the NHS? So do we want it to look a bit more like health, or do we want it to really listen to the voice of people who think about kind of what it means to live a good life, what kind of gloriously ordinary life might be for them? And so we might think of something like registration of care workers as being a kind of policy that sits sort of right at the centre of that seesaw, where the people who think that the registration of the care workforce is key are often saying that because as well as improving workers' rights, which is of course really important, it's a step towards making care more regulated, consistent, safe, and possibly more integrated with the NHS because of kind of a sense that the 2 workforces look more similar. People who argue more for a kind of self-directed, more direct payments, less kind of consistency in the system are often nervous around registration because of the feeling that a very professionalised workforce brings with it notions of kind of power and control and kind of taking us back to maybe a sense of kind of the paternalism that's a kind of very problematic legacy of the state in relation to disability. And if I want to employ a personal assistant to take me out for the day and they're not on a registered, well, that's my risk and I want to take that risk and I don't want you to tell me that I can't because you're really trying to turn NHS, the social care, into something that looks more like the NHS. And what you can see in all of the 4 nations is a kind of either fusing of these. So take the Feely report in Scotland, it basically sort of says, we'll just do all of these things all of the time and we will not worry at all about the fact that they're really pulling in different directions. You know, or you could see in the kind of Scottish legislative agenda, you might see that they passed the Self-Directed Support Act, which was much more about let's have more direct payments, let's give more power to people to say, this is what makes a good life for me. And then move really quite quickly onto integration with health and passing legislation around that, and a sense from our interviewees that they just forgot about self-directed support. They just kind of like, oh, here's a shiny thing over here, we're going to move on. And so self-directed support became very underloved and really wasn't followed through on as an agenda. So there's clearly some things going on around policy that we need to be thinking about. If we move then into the more of the sort of politics side of things, so is the problem the politics instead of or as well as the policy, then we could think about institutions. So we would say a couple of the things on the drift and the drift criteria relate to institutions. And particularly, we might focus on agenda capacity. So to what extent have our political institutions got the agenda space to really make the kind of commitment that's needed around moving to a different, more appropriate approach to social care. So what we found in the research there was that Scotland again had the most, what we call the most conducive policy environment, because we found that in the smaller nations. It was easier to make policy. It was a more consensual policy environment. At the point of the devolution settlements, all of these were set up to have executive and legislative functions that didn't look like Westminster. So partly in the way they were built, but also in the way they sought to build a kind of a more consensual style of politics that moved away from majoritarianism. Obviously in Northern Ireland for very, very specific reasons there and a very particular kind of institutional design, but also in Scotland and Wales, an idea that these would be chambers that were not built on the Westminster model and weren't trying to achieve that kind of politics. So we see Scotland has that, and Scotland also from the much earlier than Wales has full legislative scope, so it can do much more. It gets more reason it's got social security powers, but it had that kind of ability to make its own legislation and have an executive much earlier than Wales. So we would say that whilst Wales and Northern Ireland both have that kind of small state advantage, they didn't have the institutional capacity in order to kind of make the most of their smallness. Northern Ireland because of the suspension of the executive for quite a large part of this period, and Wales because it was playing catch up with Scotland because the institutions that they were kind of gifted by New Labour in 1998 were so much weaker than those in Scotland. So it's taken a long time to get kind of government, to get a Senate, to get the kind of policy making powers that allow it to kind of to pursue its own path in social care. And in England, we can say that agenda capacity has been really difficult to find, partly because of things like Brexit, like COVID, and the kind of adversarialism or political context. And something I think is quite interesting in this space around kind of institutional capacity for learning is how little learning they've done from one another. That if you kind of speak to, particularly if you speak to people in Whitehall, it does not seem to be common to be thinking, well, you know, Scotland's had free personal care for 20 years. Let's go and kind of knock on their door and find out how that's worked. There is not a curiosity about what's going on in other parts of the UK. In Scotland, they've kind of quite famously, I think, looked more to sort of Nordic models. I know you've had a session on that here. We did see Wales and Northern Ireland talking about Scotland as a kind of thought leader in this space, and that potentially Scotland was where they were looking at. But if you remember that for most of this period, different political parties were in power in all of the four nations, that gets in the way as well of having these kind of open dialogues and learning. So this quote from the Institute for Government, it's actually easier to go to Sweden than it is to potentially call up somebody in the Scottish government and say, you know, what are you doing? So that's institutions and then interest. So this is the sort of the third bit of those three I's. It's kind of what's going on around interest, by which we might say that includes political parties, it includes the different bits of government, so maybe the Treasury, it includes those kind of what we might call the veto players, so other bits of maybe the health system who can get in the way and block change. And as I said, we saw a lot of that in England, and I think it's been growing in Scotland as well. A lot of this policy literature and literature about policy failure is US literature. And one of the things they talk about in a system which is obviously very divided is about the role of political opponents in kind of sabotaging legislation. But what I think is interesting in England, if you look at the kind of the saboteurs of the care cap, so care cap passed into legislation twice, never implemented. But in both cases, it was the incumbent government who itself had passed the legislation that pressed pause and then ultimately did not pursue the agenda. So we're sort of, it's almost like kind of that sense of kind of, you know, the sabotage is coming from within, that this is not about political opponents mobilising, it's about the Treasury and parts of the Conservative Party saying that they don't want to proceed with the reforms. Obviously, the very volatile context around Conservative Party leadership, you know, quickly through Prime Ministers was part of this. They were outdoing each other to look fiscally conservative. Part of that was abandoning the levy, which would have paid for part of the care cap. So we can kind of see here that that it's partly really those kind of interests within the Conservative Party that have made a big difference to drift. I guess what's also interesting is local governments. The Local Government Association has also been active in arguing against the care cap, partly because it said it doesn't have enough money and they're doing it too soon. But I think once you get that kind of coalition of both the government and the Local Government Association saying we can't do this, then it becomes very difficult to proceed with the legislation. And as I said, in Scotland, where we saw quite a conducive institutional environment and a fairly consensual political approach over 20 years around the social care reforms, that there's been a sense that that is no longer the case, that almost when Nicola Sturgeon went, so did the political capital to make a national care service happen. That, you know, the kind of the problems that they've had around leadership since then has really made it very difficult to sustain the kind of political momentum to do all sorts of things, but particularly to see off some of the veto players around the National Care Service, because of the way that the proposals managed to unite so many opponents against it. So I guess that takes us to a position of relative pessimism around what's possible, and a sense that maybe we are kind of in a position, we've kind of moved through drift to decay. And I suppose what's kind of interesting in relation to decay is that we need to think about that perhaps more holistically. So I've got a graph here, it might be a little bit blurry, but the key, it's about local government spending in England between 2010 to 11 and 2023 to 24. And the key thing is the only thing that local government is really spending any money on now is adults and children's care services. So, you know, in a way, it's not like care not getting any money, but because of local government's statutory responsibilities, that's where the money is going. Everything else is being hugely cut back. And I wanted to share that just as that sense of sort of circling back really to that sense of what makes a kind of flourishing ecosystem in care. You cannot have a flourishing care ecosystem if this is the kind of pattern of spending within local authorities. So whereas we said that a flourishing ecosystem should look like this, if the only thing you're kind of spending money in, you kind of maybe swell the statutory sectors, but at the expense of everything else. I'm kind of feeling that if you've got no community centres, you've got no spaces to go, your kind of your public environment is unpleasant, it's not safe, then you know you're kind of storing up all sorts of problems, because there is not ever likely to be enough money for the formal institutions to be able to meet the demand for social care. So unfortunately, this gets us back to this, and feeling that a kind of decaying system ends up looking like this. To finish then on a question of kind of where next, will a national care service save us? Hopefully that's something we can get into in the questions to get a sense of kind of what other people think about this. It's clearly an NHS for care in the sense of borrowing the branding from that. That doesn't necessarily mean it's borrowing the kind of all the elements of an NHS for care, but nonetheless that's kind of what it's trying to project in using that language. There was a sense that Scotland again were kind of venturing out the furthest and fastest on this. But one of the things that they did was they sort of went beyond, I think, the initial kind of kernel of the idea into something which was really very ambitious and created a lot of hostility against it. It was going to take social care away from local governments, put it into independent care boards. So immediately local government hates it. There were going to be changes to GPs' practices, so GPs didn't like it. They were going to do something around the children's family courts. So I think part of the problem in Scotland was they mobilised too many veto players at once at a time when the capital of Nicola Sturgeon was in decline. So that now is back in the kind of drift/decay. And of course, once you kind of had to drop these things, there's the kind of it's a sense of the kind of political risk of picking them back up again. So I kind of sense that then there's got to be a sort of time lag before it might feel appropriate to resurrect the idea. Wales is kind of quietly getting on with the National Care and Support Service, so don't yet know quite what that might look like, but there's been less, I think, potentially maybe a more consensual approach in Scotland. I haven't heard the same sense of kind of outrage from some of the interested parties around that. And then here we are in England with the Casey Commission coming into being, which will do some preliminary reporting next year, but will have its final report in 2028. And I guess some of the kind of questions around that, which is sort of why I wanted to really focus on this in the talk tonight, was a lot of people saying, Andrew Dill not included, we know what the policy is, we know the policy solutions, we don't need another commission to look at that. We've got to get the politics right, and how might we go around doing that? And other people saying, there's various policy solutions on the table. We don't know which one to choose. So actually, there is work for the commission to do around working out what the policy should be. Let's start kind of wrapping up. In terms of kind of moving away from drift, so partly it's about recognising there's lots of great stuff on the statute books already. So the Care Act 2014 is a fantastic piece of legislation. It's not implemented, partly because of the kind of austerity context. So with a kind of more positive kind of investment in the sector, the scope to do things already without needing to embark on new legislation. I think if policymakers were more kind of aware of some of these drift factors, there might be kind of a more better tactics around care policy making. There are questions about what's the right space to intervene. If with the devolution white paper, we're going to be getting strategic authorities across England, then maybe we need to be talking to them and thinking with them rather than this being kind of the National Care Service Commission doing something over here and the devolution white paper doing something over here without any kind of apparent attempt to connect them. We need to be thinking about the policy mix and we need to make choices that we cannot necessarily do all of the things that the policy is trying to do all at once. And that there are some advantages into doing what Scotland did, which is a sort of stage set of reforms, that if you try and kind of do all at once, as they later did for the National Care Service, maybe that's too big and it becomes unwieldy and it fails. But if you do things more sequentially, as they did in those early periods of devolution, then maybe you might get further. So in conclusion, lots has happened. There is a sense that maybe we're on the brink of further reform, particularly in parts of the UK. There was a period in Scotland, so when we were, the book was just out in 2023, one of our talks was kind of, let's retire to Scotland, that Scotland seemed to have all of the right things going on around social care, but I think the kind of the retrenchment, more recently maybe it makes that not quite so clear. I think none of them are recognising the tensions in this. And then finally, there's no simple kind of NHS for care model that can be taken off the shelf. And that's partly about policy design, but it's also about policy learning and the implementation. So there's no point passing new legislation that is then sidelined and ignored. We need to think how to make change happen in localities, in places, and the things that will lead to people having those gloriously ordinary lives. Thank you.